Bismillah ar-Rahman ar-Rahim. May I have the pleasure to co-chair this session with Professor Elisabetta Todisco from Italy, huh? And Dr. Safa Ramadan, HIE, and now in English. Supposed before in Italy, so it's international. The first presentation in this session is by Dr. Amani Muhammad Ali from Acute Cancer Center, and the title of the presentation is Overview on Pediatric Non-Hodgkin Lymphoma. Dr. Amani.
بسم الله الرحمن الرحيم. متشكرة جدا على البرزنتيشن ومتشكرة على الانترودكشن بتاع حضرتك يا دكتور. ان شاء الله هنتكلم عن الاوفر فيو اوف بيدياتريك نون هودجكن ليمفوما. كان امبارح كان في برزنتيشن عن السوهاج كانسر سنتر اكسبيرينس ان مانجمنت اوف بيدياتريك نون هودجكن ليمفوما. ان شاء الله النهارده هنتكلم عن الاوفر فيو اوف بيدياتريك نون هودجكن ليمفوما. دي الأجندة. Introduction. Lymphoma in pediatric, the third cancer diagnosis. The majority non-Hodgkin lymphoma represent 60% and Hodgkin lymphoma 40%. Non-Hodgkin lymphoma accounts for 7% of cancer in children. At our cancer institute, South Egypt Cancer Institute, lymphoma represent 10% of admission, and in Sohag Cancer Center, lymphoma represent about 8% of admission. Non-Hodgkin lymphoma, a diverse group of malignant neoplasm of lymphoid tissues, of B-cell or T-cell progenitors, mature B-cell or mature T-cell in sites of immune system, lymph node, bone marrow, spleen, liver, and GIT. The peak incidence in pediatric lymphoma from 7 to 10 years, uncommon to see lymphoma below 2 years. There is predominance of male sex as 2.5 to 1. Pediatric non-Hodgkin lymphoma are high-grade malignancy and clinically very aggressive, unlike in adult where lymphoma low grade and usually localized. The patient presents at advanced stage, the majority, 85%, with bulky disease and high LDH level, malnutrition, anemia, and dissemination to bone marrow and CNS. When we talk about lymphoma when primary presentation is mass with minimal blood and bone marrow manifestation. And if infiltrated bone marrow, the blast number must be less than 20% and patch infiltration. Leukemia if primary presentation in the blood and blast cell more than 20%. In pediatric lymphoma, the combination chemotherapy is the cornerstone on management. Etiology, usually unknown etiology in pediatric cancer, but associated with viral infection, especially Epstein-Barr virus and HIV. Immune deficiency, there is increased incidence of lymphoma more than 100-fold. Regarding pesticide and prenatal or postnatal drugs or radiation exposure, all not associated with increased risk of lymphoma. WHO classified the lymphoma into two groups, B-cell lymphoma and T-cell lymphoma. The majority, B-cell lymphoma, arising from mature B-cell or precursor lymphoblastic lymphoma. The majority of mature B-cell, the Burkitt's, about 40%, and the diffuse large B-cell lymphoma, 20%, and rare types, very rare we see these types. Also, mature T-cell lymphoma, في precursor T-cell lymphoma, في mature T-cell lymphoma, and the cases of lymphoblastic lymphoma is very aggressive and presented in more number in our institute. Regarding the clinical presentation, lymphoma respect the type or immunophenotype. If B-cell lymphoma usually presented in the abdomen. T-cell lymphoma presented supradiaphragmatic, mainly in the mediastinum. About 60 to 70% of cases. Abdominal lymphoma usually presented early or late. Early, usually the patient presented with history of abdominal pain, abdominal distension, abdominal obstruction. By imaging, عادة revealed intussusception. All these patients presented from surgical department as surgical excision and re-anastomosis of the tumor mass. And this patient diagnosed as stage 2 non-Hodgkin lymphoma. Advanced abdominal lymphoma عادة presented from abdominal lymph nodes or infiltration of the organ, usually liver, spleen, kidney, ovarian. No bulking surgery in pediatric lymphoma. In case of laparotomy, no attempts to remove the tumor, only simple biopsy. This patient presented by huge abdominal mass and passed to surgery, right hemicolectomy 2 weeks earlier. After surgery, the patient presented by problem of healing, and usually this patient presented by local progression and dissemination to bone marrow and CNS. This patient, the better management, only biopsy. Mediastinal presentation, respiratory, usually patient presented with mediastinal mass, presented by respiratory distress, signs and symptoms of severe vena cava syndrome, pleural effusion, pericardial effusion. All these patients diagnosed as stage 3 lymphoblastic lymphoma, which yearly transformed to ALL. This patient presented by huge mediastinal mass and presented by mediastinal syndrome, severe vena cava syndrome. In this situation, no attempts to give patient general anesthesia for biopsy. The diagnosis can be made by cytology from pleural effusion, bone marrow, peripheral lymph node, or peripheral blood total differentiation if there is blast cell. Head and neck presentation in 20% of the patient, usually patient presented by tonsillar hypertrophy, nasopharyngeal mass, oropharyngeal mass, or patient presented by huge cervical lymph node, and very usually presented by huge cervical lymph node and very wrong and quick excision biopsy in non-Hodgkin lymphoma. In time of healing of disease, progression occur and stage becomes this. Endemic Burkitt's lymphoma of the jaw. Sub-Saharan Africa has a unique epidemiology of childhood cancer. Endemic Burkitt's lymphoma, the most common, 1/3 to 1/2 of all oncologic diagnosis was Burkitt's lymphoma. Endemic Burkitt's lymphoma associated with Epstein-Barr virus in about 95% of cases. Sporadic Burkitt's lymphoma is associated with Epstein-Barr virus in 15%. This is the situation in Egypt. These types of lymphoma, subcutaneous lymphoma, presented by swelling around the eye or swelling related to the skin, usually diagnosed as B lymphoblastic, usually infiltrate CNS and the bone marrow. Other sites, patient may present by bone lymphoma, very rarefaction للبون and presented by severe pain, or renal infiltration. Bilateral renal lymphoma, to differentiate between bilateral infiltration and Wilms tumor. Usually lymphoma presents as bulky or edematous kidney. There is diffuse infiltration of the kidney. لما اتكلم عن البيدياتريك ليمفوما لازم اقول ليمفوما therapeutic emergency. So speedy assessment of diagnosis and types, staging, and assessment of general condition of the patient and metabolic assessment. Diagnosis. The first point of diagnosis, detailed history taking. Usually, pediatric lymphoma presented by short history, very short history. Within 1 month, 1 week, the patient presented by huge mass. Short history usually matches with pediatric lymphoma. Complete physical examination عشان طبعا نشوف assess tumor burden, general condition of the patient. Laboratory studies to assess tumor lysis syndrome, the very essential and very emergency situation in pediatric lymphoma, management of tumor lysis syndrome. Radiological studies, basic radiological study, PET scan now become the base for management and assessment of response in pediatric lymphoma during treatment. Pathological study for differential diagnosis of pediatric patient as lymphoma, one of differential diagnosis of round small cell tumors. Immunohistopathology regarding the type B cell or T cell for treatment according to subtypes. Cytogenetic and molecular biology to detect specific translocation for target therapy. After diagnosis, we do staging for the patient. The most appropriate staging system for non-Hodgkin lymphoma, St. Jude staging system, more appropriate and predictive of prognosis in childhood non-Hodgkin lymphoma, compared with the ARPOR staging classification used for Hodgkin lymphoma. As risk stratification, proper treatment, improve survival. Risk assessment mainly for mature B-cell lymphoma, the FAB and LMB groups stratify the patient into 3 risk groups according to the stage and treatment according to the stage. BFM group incorporate the LDH level at presentation with staging into 4 risk groups. This slide shows a better certification of BFM group as the patient stratified into 4 groups, R1, R2, R3, and R4, and the serum level of LDH is a very predictive, good prognostic tools in pediatric lymphoma. FAB classification depends mainly on the stage into group A, B, C. That's St. Jude. Treatment, usually in pediatric lymphoma, no surgery except, no local radiation except, the main treatment, chemotherapy. Treatment of lymphoblastic lymphoma based on protocols for ALL produce excellent survival rates. Treatment for Burkitt's lymphoma, multi-agent combination chemotherapy with or without immunotherapy. Now BFM group and LMP group use rituximab in their protocols for management of pediatric lymphoma. في specific protocols for rare subtypes. Rule of surgery قلنا احنا no surgery except biopsy for initial diagnosis, exploratory laparotomy in patient with acute abdominal emergency, and surgical resection if localized tumor, or residual mass after chemotherapy for careful pathologic diagnosis if this is a disease or fibrosis. No role in tumor debulking or for second look surgery. Role of radiotherapy. The radiotherapy is very effective in lymphoma, but it is a local therapy and non-Hodgkin lymphoma in pediatric, a generalized disease. Old tool. Indication only emergency situation as spinal cord compression and superior vena cava syndrome. ده برضه كان old tool. Now the diagnosis is very rapid and the patient passed to chemotherapy protocol. Mediastinal localized residual tumor. In some protocols, there is a role for radiotherapy in residual tumors. Also, cranial radiotherapy in patients presented with CNS tumor involvement in some protocols. Update in management. CD20 present in greater than 98% of cases. So rituximab, when used in treatment of adult and children with relapsed or refractory B-cell lymphoma, the result is excellent. So the Children Oncology Group study introduced rituximab with ICE for management of relapsed or refractory lymphoma. Now the BFM group and the FAB groups evaluate the efficacy of rituximab with a significant response. Also, the role of PET scan established for initial evaluation, staging, and response assessment. Regarding bone marrow transplant, the need for bone marrow high-dose chemotherapy and bone marrow transplant also decrease with improvement in survival with intensive chemotherapy, only indication if there is initial poor response or relapse which not response to second line. Prognosis of pediatric lymphoma is changes in the last 20 years as a result of better understanding of pathological processes and better use of intensive chemotherapy regimens. A 5-year survival in early stage about 98 to 100%, in late stage 3 and 4 about 90%. Patient presented with stage 4, especially patient with CNS involvement, have a worse prognosis. Prognostic factors, the most important prognostic factor and indicator to guide treatment in pediatric lymphoma is the patient response to therapy. So all patient response after fractionated COP, we assess the response of, if the response less than 20% or more than 20%, so the modification of treatment according to initial response. And also the more prognostic also tools, LDH serum level and stage SWA localized versus extensive. Thank you.
Thank you very much, Dr. Amira, for this complete presentation. And we know that you have to run to the travel. Just one question out of curiosity.
Yes.
So, what is the most common type of lymphoma you see in children in your institute?
In our institute, South Egypt Cancer Institute, in South Egypt Cancer Institute, the most types we see Burkitt's lymphoma, abdominal Burkitt's, yes.
And they have a presentation more abdominal or more cervical?
The more side is abdominal, but we see neck and the head, yes.
And do you test for EBV, for Epstein-Barr?
Not routine, in some cases.
Okay, it would be interesting to
For young cases, young patient when presented lymphoma in age 3 years or 4 years can assess Epstein-Barr virus. Yes.
It would be interesting to collect this data. Thank you very much.
Okay.
Can I ask a question as well? Because of your wide experience in Burkitt lymphoma, whenever the lymphoma, the child comes at diagnosis with an abdominal urgency, and so you have to do surgery. And for example, if you find a peritonitis before a perforation, for example, and the child survives, then how do you manage to go on with intensive chemotherapy? After how long time, or you reduce chemo dosage, maybe fractionating it,
Yes.
or what do you usually do if you have the perception by the PET scan that you have a massive visceral infiltration?
So
In this,
I think we can divide this into many questions. So the first one, in your experience, when you treat patients with Burkitt lymphoma of abdominal mass,
yes.
so did you see perforations and complications like that? And how do you do with them? Do you send them to surgery? And even if they did the surgery and had also some infective complications like peritonitis, how do you restart your intensive therapy?
Initial chemotherapy we give fractionated COP, fractionated cyclophosphamide steroids. vein crescent, and can repeat fractionated COP twice till the general condition and the laboratory investigation of the patient is stable.
So you don't continue BFM, you go for something less intensive?
Until we do fractionated chemotherapy until the general condition improve and the laboratory test improve.
Very, very interesting, and I think this is the way indeed. You give less intensive, more fractionated, and then when the patient is better, you can go back to your intensive therapy again?
Yes.
Fractionated COP, but the interval time between the two fractions, 15 days, 21 days, or usually?
Always we give fractionated COP on 2 days. We do assessment on day 8, and if there is disturbance in the lab of the patient, we do another COP. And 1 week between the 2 cycles.
Very, very good.
Thank you.
Thank you. So now we will move to minimal residual disease in multiple myeloma with Dr. Gamal Fathi from Nasrin Institute.
First of all, I would like to thank all the organizers for inviting me to this event, and of course to thank all the chairmen. Actually, the topic today is about the MRD. MRD, I think, in several disease entities is now the importance a little bit starting to be how can I use this? Of value. كده مظبوط? Okay. So the topic will be about MRD, but this day in multiple myeloma, raising a question with, are we curing? Multiple myeloma is a plasma cell cancer where there is an overproduction of monoclonal proteins and paraproteins, plus ineffective immunoglobulins that lead to marrow failure and destruction of bone tissue. It's the second most prevalent hematological neoplasm with a median age of diagnosis around 70 years. But in Egypt, I think we all know that we have a lower median of age. We have frequent cases of myeloma at the age of 30 and 40. And the survival is increasing in the last 10 or 15 years after the novel agents. The incidence in USA, for example, 1.8% of all malignancy. The incidence is 1 per 100,000 per year. And in Egypt is 0.5% of all malignancies in males and 0.34 for females. And the number in 2020 is around 552 cases and expected to increase to more than 750 cases in 2025, with the incidence 1.5-fold increase in men rather than women. Simply to tag a patient as a myeloma, you should have a clonal plasma cells plus a monoclonal protein detected either in the serum or in urine. For staging of myeloma, we have the old ISS staging system, having the variables with the beta-2 macroglobulins and the albumin, and if your patient is it's less than 3.5 milligram per liter beta-2 macroglobulin, and the albumin is above 3.5, so this is stage 1, and moving to stage 3, where the beta-2 macroglobulin more than 5.5, and in between it's the risk class 2. Adding the cytogenetic or the fish signature to the staging system will put the new model for risk stratification, which is the revised stratification, where if the panel is standard risk, it's stage 1, and if the high risk, it's stage 3, and in between, not 1, not 3, is stage 2 revised. Overall survival is inversely proportional to the degree of the risk criteria. That's to say, the lower the risk, the better the overall survival, as you can see from this curve. When we start treating cases of myeloma, usually we divide cases into transplant eligible and ineligible. Both should receive the first component of therapy, which is the induction. And then the journey will differ. For transplant eligible, we'll go for transplantation and then maintenance therapy, but for ineligible cases, the consolidation and maintenance are continued therapy. It's only maintenance, there is no transplant, and then comes the nightmare, which is the relapse. Moving to the response. The response differs, and the depth of response differs from case to case, and of course it is related, and it's one of the major prognostic factor in myeloma. So whatever the age of patient, the depth of response will matter in the prognosis of the case. And we are following with these parameters: the serum protein electrophoresis, the serum and urine immune fixation, serum free light chain ratio, the bone marrow biopsy in certain situations, and other labs. And as you can see, every treatment cycle you should do almost all of these, apart from the bone marrow aspirate, of course. But at any time of, and at any point you want to assess your response, you should do all, and the same applied if you are doubting a progression. These are the uniform criteria. The CR and the SCR are the best two levels of response, and they are almost the same, apart from the normalization of the free light chain ratio that's present in the SCR. And the depth of response, of course, it will be translated to better outcome. That's to say, patients in CR usually will have a better PFS and a better overall survival. But what's cure? What's cure after all? How can I say this patient is cured? Is it a matter of getting rid of the disease, or just stopping treatment and the patient will live in peace without any disease progression, or it's restoring the life expectancy? When we start treating cases with myeloma, if we achieve to kill around 50% of the myeloma cells, so this is the partial response, moving to a better achievement, which is the very good PR when killing 90% of cells, and then moving to much more better, which is the CR around 95%, and then we'll start to have a deeper response, starting from the stringent CR 99%, and then moving to the MRD, whatever tool you are using, either the next generation flow cytometry or the next generation sequencing, to reach a deeper and a deeper kind of response. CR is only a good thing, but because of MRD. What's meant by this? CR per se alone maybe wouldn't differ from even a lesser degree of response if the patient failed to achieve kind of an MRD negativity. And as you can see from these curves, the blue curve for the MRD having a superiority in the PFS as well as the overall survival when compared to other depth of responses, including CR, as you can see, the yellow curve. So can we go deeper? Recently, there is a widespread of novel agents. We have a lot to give to our patients, a lot of families of medicine, like the IMiDs, like the PIs, the monoclonal antibodies, and more. So maybe we will not be satisfied only by the traditional outcome with CR, for example, or VGPR, and I think we will all need to go deeper and beyond CR. While CR is generally being considered as a good outcome, this is not cure. And most patients, unfortunately, will eventually relapse. We all know that whatever the depth of response, tell the level of CR or even stringent CR, the patients 100% will, at the time, they're gonna relapse. So responses deeper than CR are needed to predict and to improve long-term outcome in this bad disease. This is the famous photo for the iceberg. And as you can see, using ultrasensitive methods will give us the opportunity to detect what's beyond the clinical or what's beyond the traditional tools for assessing this disease. MRD often results in eventual growth by time and then increasing the risk of disease relapse, while if we succeeded to put the patient in an MRD negative status, this may be translated later on for shorter, the presence of MRD will lead to shorter PFS and overall survival. So achieving MRD negativity should be theoretically improve and increase the PFS and overall survival, and we will see some studies that addressing such title, and we will check the results. Okay, how can I reach this? How can I detect actually this? Not to reach, to detect the MRD, we have several tools. One of them is cell-based, like multi-parametric flow cytometry. Others related to the molecular-based, which is the next generation sequencing by using, of course, we all know malignant plasma cells have a unique clonal rearrangements with immunoglobulin genes. So using the next generation sequencing may help us to detect less disease load. And finally, the imaging, like the MRI and the PET-CT. So is it relevant to clinical, the MRD, is it clinically relevant or not? Association with MRD with superior survival outcomes, as you can see from the curve, MRD negative status associated with, as we said a few seconds ago, that it is associated with better PFS and overall survival. And as you can see from the curves on the left side, the overall PFS by MRD status, the MRD negative cases has a significant superiority in PFS as well as the overall survival. And CRs also, for patients who achieved CR only, not all the patients, also have a superiority when achieving an MRD negativity. So I think MRD is better or much better than, or achieving an MRD much better than CR, as we mentioned. And as you can see, if you achieved an MRD is in a zone and other categories in another zone. So CR in the absence of MRD negativity was not associated with prolonged PFS compared even if the patient having kind of just near CR while achieving an MRD negativity. What's the value of putting the patient in deep durable response? Actually, we all know that facing a treatment-naive myeloma case or cells totally different than facing malignant plasma cells, but in first relapse or second relapse or third relapse. By time, cells gaining refractoriness, gaining more and more subclonal evolution. So it's better to prolong the time to next treatment. It's better when you put your patient today in remission to make the coming day for relapse, not after 1 year or 2 years, make it more and more and more in order not to face that monster harboring a lot of mutations, a lot of clonal evolutions. So achieving durable MRD negativity will likely increase time to next treatment or time to next relapse, which is a very good and a very important achieving. How to reach MRD? Okay, the first tool, which is an old tool actually, is the autologous transplant. And I think we all agree that doing an autologous transplant is for any transplant-eligible myeloma patient. It's not like lymphoma, for example, or other diseases treated with autologous transplant, just when the patient relapses and then I give salvage therapy and then I do the transplant. No. any myeloma patient who is eligible for autologous transplant should be subjected to such a procedure. After using the immunomide plus the PI, the protocol, which is very famous, almost standard of care, which is the RVD or VRD, and the results was extremely impressive. So this, we ask ourselves a question, okay, this triplet is very good. Can we not omit, but at least delay the transplant or even omit the transplant? This study, they gave the patients the VRD and then they mobilized cells and then randomized cases either to do transplant followed by consolidation with 2 cycles VRD and then maintenance lenalidomide, or no transplant, and they give more cycle, 5 cycles of VRD and then go directly to maintenance without transplant, and then if these patients progress, they go for transplant. At the end of the day, PFS was superior in the transplantation arm with a significant p-value, as you can see, and the hazard ratio is 0.65. That's to say there is a 30% reduction of progression or death for the transplantation arm, despite the fact that overall survival was not statistically significant, but still transplant matters for cases of myeloma. Another important issue from this curve, patients who achieved MRD negativity either in the transplantation arm or in the VRD arm behave like they have a better outcome with regard the survival. So it's the best inducer, conventional inducer of MRD status so far, and it prolongs PFS and not likely for overall survival. What about newer agents? We will go through a few studies for novel agents like second generation PI, KRD demonstrated higher rates of MRD negativity that is translated for long-term benefits in the form of patients in this study who succeeded to achieve an MRD negativity. They behaved much more better and they had longer PFS, overall survival, and time to next progression. Another famous study, which is the Pollux, where they compared a backbone of Lendex minus or plus daratumumab, a monoclonal antibody directed against CD38, and also patients who had a sustained MRD negativity, they had a longer PFS and overall survival. Moving to another study, which is the Castor study, a backbone of PI plus DEXA, Velcade DEXA, minus or plus daratumumab, the same results noted. For the Alcyone trial, where they tested or compared the VMP for newly diagnosed elderly patients versus VMP plus DARA, and then regardless of the age of those patients, the rate of MRD negativity was higher with the quadruplet. So it made a lot of sense for the International Myeloma Working Group to incorporate the MRD response assessment in multiple myeloma. As you can see, some definitions like sustained MRD negativity in the marrow using either next generation flow or sequencing or both. And for the flow MRD negative, absence of phenotypically apparent clonal plasma cells, moving to the sequencing MRD negative using the next generation sequencing, and finally the imaging based. So this slide from Professor Muhammad Abdelmati, very nice. He's answering a very important questions. Can we build up an algorithm or a policy that's MRD adapted? That's to say, I gave my patient induction. Let's check MRD after induction. If it's still positive, I will let the patient move to the second step, which is the standard of care autologous transplant. But what about if he got an MRD negativity? Shall we go to the next step or shall we wait? And the same applied after autologous transplant. If I reach the point of autologous transplant and the MRD is still positive, shall I move to maintenance? But what about if the patient now enjoying an MRD negativity? Can we omit the maintenance? And so forth. Maybe the master trial, which is a first trial that asked the question if patients in such a trial are able to have a sustained MRD negativity they can go on the discontinuation therapy using quadruplet, of course, one monoclonal, one second-generation PI, one IMiD, plus one DEXA, with minimal residual disease at that time, adapted therapy in newly diagnosed cases. They gave the patient, I'm about to finish, and I've not told, sorry. They gave the patient induction with KRDD for 4 cycles, and then according to the MRD negativity after the consolidation one, which was also 4 cycles for autologous and then KRD. If the patient is negative, it's just observation, and if the patient is positive, they gave the patient 4 cycles of KRD, and then again observation if negative, and if positive, another 4 cycles of KRDD, and then observation if negative, if positive, lenalidomide maintenance or standard of care. So they concluded that this quadruplet and autologous hematopoietic stem cell transplant and MRD response adapted consolidation leads to higher rate of MRD negativity in newly diagnosed cases. So to conclude, CR is defined by negative immunofixation in serum, urine, and less than 5% plasma cells in the bone marrow. MRD can be assessed by novel techniques like multi-parametric flow cytometry or next generation flow cytometry or next generation sequencing on a bone marrow sample, but also by MRI and PET, as well as a PET-CT. MRD negativity defined by a very highly sensitive method, sure it correlates with both PFS and overall survival. By this slide, I would like to end and thank you.
Thank you very much. I think Dr. Elizabeth has so many questions, so we will
I know you.
You can do one.
It was a very nice and comprehensive presentation.
Thank you.
My question is, so you have shown in the last few slides which are the time points, I mean, where you are going to measure minimal residual disease, because you have shown, I mean, the take-home message is very clear, MRD negativity, prolonged overall survival, progression-free survival, but when we should measure minimal residual disease. I think this is a very important point. For example, also for acute lymphoblastic leukemia, it was a very important issue, because one thing is to measure it after induction, the other thing is measuring it. So which time point is really prognostic? And then you said that the best way to do that is next flow cytometry or next generation sequencing, but how this is applicable in general? I mean, for example, in Italy, you made an effort to find an institution that measures minimal residual disease with a normal flow cytometry.
Okay.
So the presentation is very advancing the future, but under the practical point of view, what we have to do with this minimal residual disease in Europe?
Okay, very nice question. From practical point of view, there is no minimal residual disease, either assessment or adapted strategy, because it's not even easy to access in our country, and even though there is no standardization. In order to build up on the MRD and take decisions and to put an algorithm or whatever, you should have accessibility to the tool and reliability to the tool. You have to have confidence with this test that you're receiving. You cannot build up on a results that you are not trusting the accuracy of the test. So it should be available easily with a decent cost, and it should be standardized. And this is not the situation. But this is a proposed or a hope to put a strategy like that. I liked the idea of this slide, and thanks for Professor Mohammed Amati for giving me this slide. It's very smart. It's kind of, if I succeeded to have a reliable MRD testing, shall we omit the second station in the patient journey? I don't know. I think maybe yes. I think so. Like Professor Mohammed, do you want to add?
For Dr. Mohammed.
What's your opinion? معانا دكتور محمد, he has to share.
Not the value of MRD negativity, by the way. MRD negativity is good. But MRD positive can be good or bad.
And I think it's totally different story when you are talking about ALL, for example, especially in pediatrics or even in adults. It's a well-established policy. But moving to, as Professor Abdelmouati mentioned, for example, CLL is highly debatable. It depends on what line of therapy I'm giving to the patient. For example, indefinite therapy, totally different than the fixed time duration. Here I can, we can talk about MRD, for example, in the fixed time duration, but I cannot do this for an indefinite therapy like ibrutinib or something like that. The same applied for myeloma, but I think the situation of the MRD adapted strategy maybe will be much better in myeloma than CLL, for example. But of course not like an ALL, which is well established. Even in Egypt, by the way.
Yeah, but
especially in pediatrics.
Yeah, but if you, in your center, would start to do that, okay? So, on the basis of your knowledge, which is the best time point? It's after autologous transplantation because it gives the difference. Where do you want to start?
From my point of view, it will never affect my decision, of course, for induction and, of course, for stem cell transplantation, and even the maintenance. But it may affect the duration of maintenance. Because I know, most of us, there is kind of debate. Should I give maintenance after autologous transplant for 2 years, or so long the patient is not suffering from any side effects, why not to continue till disease progression or unacceptable toxicity? I think as a start, if I have a reliable MRD tool, I'm not gonna build any decisions regarding the stem cell transplantation or even the decision of giving the patient maintenance. I will give all the patients maintenance, but maybe I will start with when to stop maintenance. Inspired from CML, which is not a fair comparison. But I mean, I'm confused. From my point of view, I want to give the patient maintenance till disease progression, indefinite. Professor Abdelmouati or Professor Rafat, no, 2 years for immunomide or lenalidomide is enough, secondary malignancy, and so and so. So there is a debate. Maybe this will be clear if I succeeded to have an MRD positivity after 1 year, 2 years, whatever, so I can kind of safely stop the drug. This is, of course, from my point of view, it's not...
I mean, this is very interesting. I agree with you, because I think that stopping the therapy is our next aim, considering that drugs are very expensive and people...
And the side effects, the patient is suffering.
And the last question, I'm sorry. If you would be in the situation to choose between next generation flow, because you have you showed that the deepness, I mean, both have the same sensitivity, 10 to the power 5.
Yeah,
so
yeah.
If you would be in the situation to choose the tool, what you would choose? Next generation flow or next generation NGS?
Of course, if both are available and there is no big difference in the price, next generation sequencing. It may give me up to 1 out of a million. So I think the sensitivity is much more higher. So I will prefer next generation sequencing. What is that? This is.
Maybe I will disagree a little bit with Dr. Gamal for this answer, because in Egypt we have a special financial situation. So NGS will need an initial sample for diagnosis, and then NGS will be very important because it will be depending on the NGS preliminary IGHA regimen.
Let's differentiate between. I think I understood the question in a correct way. You're talking about the situation in Egypt or in general?
In general.
In general. Please repeat your answer in general.
In general,
We can make it into two questions, in general and
Prosec kit for NGS is very, very expensive. It exceeds $1,000 per patient. So NGS.
I said if they are the same cost.
No.
Let's talk about sensitivity.
They can give the same sensitivity. Because
Okay.
NGF, you use 10 color, Prosec and more than 10 color. NGF can give us a sensitivity to 10 to the power minus 6. So they can give both the same sensitivity. The issue is NGF, flow cytometry. Sometimes we do not need an initial.
This is a very good point.
It's not the same as NGS. NGS, we have to have first sample of diagnosis, we know the IgH and somatic lineage or plasma, and then to do the test. But with NGF flow, we do not need many time. And the cost, if we have the machine, the cost of flow cytometry will be less than NGF. It will be half the less. So for us, I mean, in Egypt,
more
it will
economic.
be better
100%.
on flow cytometry in order just to be available for the test to be available for any kind of myeloma patient for MRD testing.
Very valuable points. Yeah.
I will choose flow cytometry because we have the panel of antibodies. It's a 6-color or a 8-color flow cytometry based CD1, 17, 56, 38, 138, and 81 and 27. So it is much less costly than the kit.
Absolutely.
The only kit for NGS approved is the chlorosec, and it is a very, very expensive kit. We will start and then we will stop. We will not be able to do it. But by flow cytometry, I think we can afford, if we can afford to have an NGF, we can do it for every patient. That's without an initial sample and diagnosis. The cost of NGS is the double of the monoclonal antibody by flow cytometry. The problem with NGS, the result will appear after 2 weeks, but with NGF, the result will appear.
So what's the value of NGS here, Dr. Yasser? What's the value of NGS? So like this, they have the same sensitivity, they are half the cost, you don't need an initial sample. Why should I do the test? What's the indication of doing an NGS in myeloma patient?
Sometimes it's said that the NGF, the sensitivity is 10 to the power minus 5, but the NGS is 10 to the power minus 6.
6, yeah. This is what I know.
NGF now, you can use more than 20 color monoclonal antibody at the same sample, and then this will give you the same sensitivity. It depends on the monoclonal antibody you have.
So the glory of NGS will be fading.
You don't need an initial sample for
I know this. So there is no need for next generation sequencing anymore.
flow is less costly.
I know. That's why. This is my question. When to do NGS? When there is no substitution for NGS in myeloma?
For myeloma patient, I believe that
No.
flow cytometry will be better for us. NGS will be better for CLL patient.
I'm talking about myeloma.
Yes,
Okay.
because no other technique can do this except NGS. But for myeloma and MRD, I believe that flow cytometry
Great.
will be less costly and will be more rapid. The only problem with flow cytometry that you need a fresh sample, which
Yes.
is not the case with NGS. I need to proceed to the day you withdraw the bone marrow. But NGS you can wait because this is a DNA-based technique. So, but I mean, if people are devoted, they will do the test.
You succeeded to change my choice, friend.
I believe that before ordering an MRD testing in myeloma, just enter your patient into a stringent CR, which is a sensitivity of 10 to the power minus 3. I mean,
Yeah.
do not order MRD testing for myeloma if the patient is not in stringent CR. I mean, what do you expect?
Yes.
But if you increase the sensitivity of next generation flow cytometry, increasing the number of antibodies that you use, you said you can reach 20 antibodies and deep. And
Yes.
so the cost is still less than NGS. And do you think that in the future will be like that? Because, you know, the cost of NGS progressively is going down.
I totally agree. Yes, I totally agree. We actually, this was a question I needed to ask you when you presented your very wonderful presentation on AML. This is a common standard of practice that you do sequencing all AML patients and diagnosis.
Yeah, we do, because we do, and we actually all AML patients, of course, that I want to treat with an active therapy, which means also venetoclax as I did it, but of course, if the person is very old, I'm not going to do it that diagnosis, but not because it's old by age, but because I don't know, maybe you want to try to do induction. So I select a little bit, but at diagnosis in general, I do NGS with a commercial myeloid panel, which has 147 genes, and then in young people, I repeat it also at the time of remission, in order to, at the time of remission. In old people, we have to standardize how to follow up by NGS. This is a big discussion going on in Italy, when perform NGS after the diagnosis. But for diagnosis, you have to do that because the more recent classification taking in account a huge quantity of those mutations. So the ELN, the last one, the last publication, it's incredible. I mean, you have to know all the mutation, because otherwise you don't know if you can perform allogeneic transplantation after, first line or not. I mean, you cannot classify them.
But keep in mind that in Italy, this is reimbursed, so it's covered also, and the cost, and since it's commercial, the costs are not by any means close to what you said. For me, what you said now is a surprise. We cannot afford this as well. So it's more economic, cost-wise, and it's also covered by the health care system. And also because we have many drugs that are targeting certain pathways, so you need to know initially. Also, we have clinical trials, etc. And there is a lot of research. So the whole story is in favor of doing this. Then again, with new drugs now you lose. With new drugs now you lose also the expression of some markers. So sometimes you need to see the clonality, and with certain molecular, with next generation sequencing, sometimes you may find still the clone is present. But I don't know in myeloma how's the situation.
Anyway, I have to say one thing. Of course, I work in Milano, and also Safa was working in Milano. Lombardia, it's a peculiar situation, because in the rest of Italy, not everybody perform NGS at diagnosis. There is a very big heterogeneity.
Yeah, there are other panels in other regions that are, for example, 30, 34 genes, but we had this one that is covering everything. Again, it's a struggle, but we can make it.
Thank you.
Thank you very much. It was very interesting, as you can see. You opened that. Very heated discussion. So our next speaker is Dr. Amani Muhammad Ali. And she's going to give us an overview on pediatric non-Hodgkin lymphoma. Yeah. I'm sorry. Yeah. Thank you.
Assalamu alaikum wa rahmatullah.
Sorry, Dr. Amira Maher, thank you for being here with us. Please start.
It gives me great honor to be here with my great professors and my colleagues. Thanks a lot. First of all, I want to mention that my title is not just Management of Pediatric ALL. I will talk about Sohaig Cancer Center experience, definitely.
Very good.
So what is ALL? ALL is acute lymphoblastic leukemia, is a malignant clonal proliferation of lymphoid progenitor cells. Epidemiology, it is the most common malignancy in the pediatric age group, representing 25% of all cancers in children and 75% of all pediatric acute leukemias. At Sohag Cancer Center, especially, median age of all patients was 6 years, ranging between 2 to 17. Male to female ratio was 1.1 to 1. Treatment, broadly, ALL is a systemic disease, and treatment is primarily based on chemotherapy, adjusted according to risk stratification. Treatment of subclinical CNS leukemia is a special entity in treatment of pediatric ALL. Treatment typically consists of 3 phases: remission induction phase, intensification consolidation phase, and continuation therapy. At Sohag Cancer Center, we started treatment of ALL at Pediatric Oncology Department in 2010 by modified total therapy 13B protocol of St. Jude Cancer Research Hospital. We carried on a retrospective study from 2010 to 2014, and those patients were followed up till January 2018. Aim of our study was to assess the clinical laboratory pattern of pediatric ALL patients at our center and to assess the outcome of treatment, including survival rates and prognostic factors affecting it. Patients and methods: 79 out of 87 ALL patients were eligible for the study. Eligibility criteria: aged between 2 to 18 years, patients who admitted to our department, and ALL patients with L1 and L2 subtypes. We excluded mature B-ALL with L3 subtype, and we excluded also patients who died early before starting chemotherapy, and infantile patients less than 2 years, and some patients were having no available medical records, so we excluded them. We collected data including history and physical examination at presentation as demographic data, clinical presentation and examination including pallor, bleeding, fever, bone pain, lymphadenopathy, organomegaly, cranial nerve pulses or manifestations of increased intracranial pressure, Despin sign, and testicular enlargement. We also collected data regarding laboratory studies at presentation as CBC with differential count and routine liver function and kidney function tests, bone marrow aspirate, including morphological and cytochemical studies, which stratified our patients to either L1 or L2 subtypes, immunophenotyping, which stratified our patients to precursor B and TLL. Cytogenetic studies, or MRD, unfortunately was not done because it is costly and wasn't available at that time. CSF examination was done by CSF cytology only. So we studied our patients either being positive or negative for malignant cells. We didn't have cytospin at our center. Also, imaging studies was reported as chest X-ray, abdominal sonar, testicular sonar, CT chest, especially for patients with mediastinal masses, and MR brain imaging for positive CNS patients. We stratified our patients according to COG ALL risk classification system to either standard risk or high-risk patients. Standard risk patients were patients with B-cell precursor, aged between 2 to less than 10 years at presentation, and with initial white blood cell count less than 50, and with negative CNS disease. High risk were all other patients. We followed, as I mentioned before, total 13B protocol of St. Jude Cancer Research Hospital. We monitored our patient treatment response. We monitored their early response by CBC total and differential count only on day 8 of induction, which stratified our patients to either rapid early responders with no peripheral blasts and slow early responders with peripheral blasts. Bone marrow aspirate done on day 36 at the end of induction. Patients were either M1 with blood cell count in bone marrow less than 5%, and M2 blood cell count less than between 5 and 25%, and M3 blood cell count in bone marrow more than 25%. Patient outcome including relapse, disease, causes of death, absence or loss of follow-up, complete remission, CR, or continuous complete remission, CCR, patient survival rates, overall event-free and disease-free survival. What was the results? Most of our patients were males, 51.9%. Most of them had bone marrow aspirate with precursor B-ALL, 69.6%, and 30% had bone marrow aspirate TLL, precursor TLL. Unfortunately, most of our patients were stratified as high risk with 58.2%, and standard risk represented 41.8%. As regarding clinical presentation, most of patients presented with pallor, lymphadenopathy, fever, hepatosplenomegaly. Only 8.9% presented with neurological manifestations, and 17.7% presented with mediastinal masses, and fortunately none of them presented with testicular involvement. How we diagnosed CNS disease in our patients? As I mentioned before, we didn't have cytospin, so we depended on diagnosis on CSF cytology, presence or absence of neurological manifestations, and presence or absence of intracerebral infiltrate on MRI brain imaging. We totally had 9 patients with CNS disease. 1 of them had positive CSF cytology only. 2 of them had positive CSF cytology with manifestations of increased intracranial pressure, and 6 of them had only manifestations of increased intracranial pressure and positive MRI brain imaging findings. Treatment response, 87.3% was rapid early responders. Only 12% were slow early responders. Bone marrow aspirate on day 36, most of them fortunately was M1 with 94.5%, and 4.1% was M2, and 1.4% was M3. This algorithm show our patient outcome. We started with 79 evaluable patients. 6 of them died during induction, and 4 of them achieved or encountered induction failure. Only 69 out of 73 achieved CR. 6 of them died in CR, 19 patients, 26% died due to relapse, and only 1 patient lost follow-up. The remaining 47 patients are still, alhamdulillah, in CCR. This is mostly was due to disease progression. 2 cases died due to sepsis, and this is NCR was mostly due to methotrexate toxicity. 4 years overall survival for all patients was 64.1%. And for standard risk was 57.5%, for high risk was 68.6%. Event-free survival, 4 years event-free survival was 57% for all patients, and 57% for standard risk, and the same for high risk. Disease-free survival was 70% for all patients, 74% for standard risk, and 68% for high risk. We studied the effect of prognostic factors on patient survival as age, gender, initial total leukocytic count, immunophenotyping, risk stratification, treatment response on day 8 of induction, and day 36 bone marrow aspirate at the end of induction. Only initial total leukocytic count and day 36 bone marrow aspirate had significant statistical effect on survival. We can conclude that the majority of our patients were stratified as high risk. Most of them achieved rapid early response and CR. CNS disease and TLL subtype were at higher rates than other national and international studies. There was high relapse rate, 26.4%, and the death rate, 39.2%. Most of this were due to relapse, but sepsis and methotrexate toxicity were the predominant cause in CR disease. Survival rates were lower than internationally reported results. And as we mentioned, bone marrow on day 36 and initial total leukocytic count had significant statistical effect on event-free and disease-free survival. This is our study, was published in Research in Oncology Journal, and was published as an abstract in the African SIOP in 2019. Future of ALL at Sohail Cancer Center. Today, we have better diagnosis and risk stratification by improving our lab facilities, flow cytometry unit, hematology unit, microbiology unit, and electronic medical record for all patients' data. We are now doing cytogenetic studies by FISH technique for all patients, but unfortunately, it is not done at our center. It is done at South Egypt Cancer Institute. We have better treatment plans. We intensified our treatment. We introduced total 15 therapy of St. Jude Cancer Research Hospital, especially for high-risk patients. We have a very developed 3D radiotherapy unit at our center. We have better assessment of response to treatment by MRD. Now it is done at the end of induction for all patients and done on week 7 of maintenance treatment for low-risk patients. We have better outpatient services. We add another clinic with pediatric oncology specialists to meet the increasing patients flow. We improved our daycare unit for chemotherapy injection. We have better hospitalization facilities and infection control measures by new hematology unit confirmed with 10 beds, and it has its specific clinical pharmacy with highly qualified trained nursing team for drug preparation under complete aseptic condition. We have also a highly equipped and developed ICU with 5 beds. What is our pediatric oncology department at Sohag Cancer Center? Sohag Cancer Center was instructed on 1999. Our pediatric oncology department was instructed on 2004. It started with inpatient department, only 9 beds, 1 outpatient clinic, and 2 residents, and 1 consultant. Now we have inpatient hematology unit, 10 beds with its clinical pharmacy, solid tumor unit, 24 beds with its clinical pharmacy, ICU, 5 beds, 2 ventilators, 1 ultrafiltrate, and 1 neonatal ICU. Outpatient, we added another clinic. We have 2 clinics. We have infusion department for chemotherapy with clinical pharmacy. Our manpower also increased. We have 2 consultants. Our professor, Dr. Amani Muhammad Ali, is one of them. And 2 specialists, 3 assistant specialists, and only 2 residents. Let me take you on a tour in our department. This is the infusion department for chemotherapy. This is our outpatient clinic. And this is our pediatric leukemia unit. This is a medium intensive care room in the department. We have platelet checker also in our department. This is our pediatric solid tumor unit. All these efforts is done by the help of the healthcare system and by the society. This is our pediatric ICU. Tomorrow, inshallah, we wish to have our own cytogenetic unit and our own bone marrow transplantation unit. Thank you, and thanks to all my colleagues and my team in the department. Especially, I want to thank Dr. Salah Farghali Ahmed. He is the godfather for the department and for the team. And thank my colleagues, my other colleagues, Dr. Ahmed Tawfi and Dr. Muhammad Salah.
Thank you very much. Very nice. Very nice.
Thank you, Doctor.
Congratulations.
Shukran.
Only one question, because we are running out of time. If no questions, I would ask Dr. Reem to come. And thank you very much.
Thank you, Doctor. Thank you.
And speak to you.
I will interrupt this beautiful session for just one moment. Please, I will call Professor Dr. Muhammad Abdul Mati to the stage. Dr. Safa, Dr. Elizabetta, we want to thank you very much in the middle of the session for coming all the way from Milan to join our meeting. You've been very supportive, both of you. Thank you very much. Professor Elizabetta.
Thank you very much for this very nice surprise. We are very emotional now. I don't know if we can continue the session, but we will do our best. So, our next speaker now, Dr. Hosam.
Hosam al-Ashtuqi.
Okay, I didn't want to pronounce it badly. He will speak about a very important topic, which is Hodgkin lymphoma immune therapy. Get the green light for use. Thank you.
Thanks, dear Professor. At the end of our mega event, I will try to be very concise. Thanks, Professor Reem, for the invitation. My talk today is Hodgkin lymphoma immunotherapy gets the green light for use. This is my agenda. Incidence of Hodgkin lymphoma in European Union is 2.3 per 100,000. The mortality is 0.4 per 100,000. We have 2 peaks, 15 to 30 and above 55 years. The estimated incidence in year 2022 in US is 8,500 with estimated deaths of 920 cases. And the 5-year overall survival is 87%. And as we all know, it has a highly curable with the frontline therapy. What about the relapsed and refractory disease? At the primary refractory is 5 to 10% to the initial treatment. We have on relapse 10 to 30%. The salvage chemotherapy regimen is similar to the non-Hodgkin lymphoma. The aim of the salvage chemotherapy is to increase the CR rate and proceed to autologous transplant. This is the 5-year PFS with and without autologous transplant. Without autologous transplant, we have 17%. With transplant, we have 31%. Overall survival, 5-year overall survival, without 26% and with 43%. This is what the autologous transplant can add to our patient. However, not all the patients are eligible for to transplant, and the outcome are poorer for elderly patients with relapsed and refractory Hodgkin lymphoma. What about the treatment for the relapsed refractory? Here we have 4 lines of treatment: the chemotherapy, conventional salvage chemotherapy, the targeted therapy, the autologous transplant, and finally the checkpoint inhibitors. As we all know, we have a very high rate of toxicity with the salvage chemotherapy: hematological, pulmonary, cardiac toxicity, and neurological toxicity. And eventually, we have a higher rates of grade 3 and 4 toxicity. This is a timeline approval by the FDA for the new agent. First, we have the brentuximab in year 2011 for the relapsed situation and after autologous transplant. Then we have Nivo at 2016 after autologous transplant and the brentuximab, and Bembo in the year 2017 relapsed after 3 lines of therapy. Then again for the brentuximab for the frontline situation in the year 2018, and finally we have the Bembo again in the year 2020 for the relapsed adult Hodgkin after any number of therapy and for pediatric patient after 2 prior therapies. This is the brentuximab. This is the structure. It is the antibody drug conjugate, as we all know. And this is the 3 situations where it is approved: the untreated in the first line in combination with chemotherapy AVD, and for consolidation after the transplant for the high-risk patient, and for the relapsed after failure of autologous transplant or 2 prior multi-agent chemotherapy. Here is the updated results from the Echelon 1, the untreated classical Hodgkin lymphoma first-line therapy, overall survival analysis of first-line brentuximab vedotin with EVD versus EBVD in classic advanced Hodgkin lymphoma. It was presented in the ASCO 2022. Here is the updated results. Here is the study design. It included patients with stage 3 and 4 only. And this is the final results. We have, after a 6 year of follow-up, we have a significantly improved overall survival among patients with advanced classical Hodgkin lymphoma treated with first-line BV with EVD. The hazard ratio is significant, 0.59, and we have overall survival improved despite the high rate of subsequent therapy used in the ABVD arm. Investigator concluded that BV with EVD should be considered as a preferred first-line treatment option for patients with untreated stage 3 or 4 classical Hodgkin lymphoma. The second situation for the brentuximab is the consolidation after the autologous transplant. We have the phase 3 ISERA trial, brentuximab vedotin in patients with Hodgkin lymphoma at a high risk of progression after transplant. This is a study design for up to 16 cycles of brentuximab after autologous transplant versus placebo. And of course, the result was in favor, after 5 years, was in favor of the brentuximab with a 5-year PFS rate of 59% versus 41% for the placebo. The last situation for the brentuximab vedotin is after failure of 2 prior multi-agent chemotherapy. It has been used in combination with brentuximab and as a monotherapy, and we have optional autologous transplant at any time after cycle 2. And the result was in favor of the brentuximab vedotin. We have a higher rate of overall response rate, 93%, and a CR rate of 74%. It has been approved in a lot of situations, as you can see, alone, and in combination with bendamustine, and also in combination with nivo. We will explore it later. What about the immune checkpoint inhibitor? Our focus today, the immune checkpoint inhibitor, the PD-1 inhibitor, it is a practice changing in relapsed Hodgkin lymphoma with the highest overall response rate for any cancer type. Both pembo and nivo are approved. The current focus is in introducing the immune checkpoint inhibitor in frontline therapy. First, the nivo, the first phase 1 and 2 study of brentuximab vedotin plus nivo for the patient with relapsed or refractory classic Hodgkin lymphoma. This is a study design, adult patient with relapsed refractory situation to frontline chemotherapy, no prior BV or salvage treatment before. Brentuximab is a stage 1 and 2 trial, one arm only, for 4 cycles of brentuximab plus nivo. Here is our results. We have a higher rate of overall response rate, around 83%, and a CR rate at the end of treatment after 4 cycles only 62% is a good or accepted results for this combination. This is a final conclusion. BV plus nivo associated with a higher overall response rate, and it was well tolerated, and 54% of 60% patients succeeded to proceed to autologous transplant, and it is a chemotherapy-free combination. BV plus nivo is associated with encouraging clinical activity in our situation. Another trial with nivo is continuation beyond progression. Patient who already progressed on nivo, they will be randomized to either continuation beyond progression versus no continuation or discontinuation of nivo. What we have of results, we have the any reduction rate is 53% for those who continue with nivo beyond progression. And this is the time for subsequent line of therapy in comparison for those who achieved, who continue with the nivo versus discontinued the nivo. And as we can see, we have a delayed time for next therapy for continuation of nivo. This is overall survival after 1 year. Those who didn't progress have the highest overall survival, 96%, and those who continued the therapy beyond progression have 83% overall survival versus 80% for those who discontinued the therapy. This is the final conclusion of this trial. Nivo was well tolerated. Investigator concluded that in this situation, patient experienced progression on nivo. Continued treatment may offer long-term benefit. Nivo plus brentuximab, but in another situation, in the younger patient with relapsed refractory classical Hodgkin lymphoma. This is the Checkmate 744 design, study design. It included patient with a standard risk patient from 5 to 30 years old with relapsed refractory CD30 positive patient after one only prior therapy for the relapsed situation. This is included an induction, intensification, and consolidation. The induction was 4 cycles of nivo plus brentuximab vedotin, and those who achieved complete metabolic response, they will skip the step of intensification and go direct for the autologous transplant. And those who achieved partial or no metabolic response, they will be moved to the intensification with brentuximab vedotin and bendamustine for 4 cycles. And again, they who achieved complete metabolic response will go for autologous transplant. Here is our results. Any time before consolidation, which means after intensification, we have an overall response rate of 98% and a complete metabolic response of 88%, which is pretty good, of course. And after only the other results, after 4 cycles of NIBO and BV only, we have overall response rate of 82 and a complete metabolic response of 59%, which is also good after only 4 cycles of NIVO and brentuximab. This is the final conclusion. A standard risk younger patient achieved a high complete molecular response with the combination NIVO-PV as a first salvage therapy, and the combination was well tolerated, and there is no apparent effect on the stem cell mobilization and collection. Moving to PEMBO, we have 2 trials for the PEMBO, the Keynote 087, PEMBO in patient with relapsed refractory classical Hodgkin lymphoma. The inclusion criteria, it included 3 cohorts of patients. The first cohort, patient progressed after autologous transplant and also received BV. Cohort 2, failed salvage chemotherapy, autologous transplant is ineligible and failed BV. And the cohort 3, failed autologous transplant and no BV after transplantation. Here are the results of the trial. PEMBO is highly active in the relapsed and refractory situation with overall response rate of 69%. Patient with primary refractory even achieved a higher overall response rate of even 80%. And of course, we know that is a tough situation, the primary refractory situation. Patient with transplant ineligible classical Hodgkin lymphoma secondary to failure of salvage therapy and BV, we have an overall response rate of 64% and a CR of 23%. No new or unexpected adverse event reported. Now we will move to an important phase 3 Keynote 204, the PEMBO versus brentuximab vedotin in the relapsed refractory classical Hodgkin lymphoma. It was published in the ASCO 2020. The included patient who relapsed after or are ineligible for autologous transplant, even relapsed after autologous transplant or ineligible for autologous transplant and failed only 1 prior therapy line. They randomized patient for PEMBO versus brentuximab vedotin as a single agent. Here is our results. We have a pretty good results in favor of the PEMBO. We have a median PFS of 13 months versus only 8 months for the standard, the brentuximab vedotin, and the 12 months progression-free is 53% versus 35% with a significant hazard ratio of 0.65 and p-value also. In the subgroup analysis, we have good results in all subgroup in favor of the PEMBO. As we can see, even your patient do autologous transplant or not, and even your patient is a primary refractory or early relapse or late relapse after 12 months. Here is the conclusion of our trial. In patient in our situation who had relapsed after or were ineligible for transplant, treatment with PEMBO significantly improves the PFS as compared with brentuximab vedotin. PEMBO achieved a more durable response than BV, no newly safety signal, and the investigator concluded that these data support PEMBO as a new standard of care for the relapsed refractory classic Hodgkin lymphoma who relapsed on or are ineligible for transplant. Finally, we have phase 1 and phase 2 study of combination of immune checkpoint inhibitor PEMBO with the new agent favezelimab. It is anti-LAG3 monoclonal antibody in the relapsed refractory situation. It has been published in the ASCO 2022. Favezelimab is a humanized IgG4 LAG3 inhibitor in early clinical development in patients with relapsed refractory hematological malignancy. Not only the Hodgkin lymphoma, it has been investigated in the diffuse large B-cell non-Hodgkin lymphoma and the indolent lymphoma also. This is the trial, phase 1 and 2 trial. It included 4 cohorts. 1 cohort for classical Hodgkin lymphoma without previous anti-PD-1 agent and refractory to anti-PD-1 agent, and the cohort 3 for the diffuse large B-cell non-Hodgkin lymphoma, cohort 4 for the indolent non-Hodgkin lymphoma. It is quite interesting. It includes two parts. Part 1, safety lead-in phase with Bembo and Favizelimab with a lower dose, then phase 2 with the standard dose of Favizelimab, which is 800 milligrams. Here is our results. We have a favorable preliminary safety and efficacy observed for the Favizelimab Pembo in patients with anti-PD-1 naive relapsed refractory classical Hodgkin lymphoma. It showed a tolerable safety profile, and we have an overall response rate of 73% and CR of 27% in such heavily pre-treated patient, and with a reduction in target lesion observed in up to 97% of patients. Median PFS is 19 months, and the study investigator concluded that Favizelimab with Bembo showed efficacy in patient in our situation naive to anti-PD-1, but this will require further study. Also, there is a lot of ongoing trial investigating the doublet and the triplet therapy like EBI and Nivo and BV. But we have a higher rate of grade 3 and 4 toxicity in this situation. This is a well-known toxicity profile of the immune checkpoint inhibitor. And finally, the guidelines. Now it is very clear in the guidelines the role of the immunotherapy. In the second line, with subsequent therapy, in the second line we have the brentuximab vedotin, with bendamustine, brentuximab with Nivo, and also we have a combination of the chemotherapy, GVD with Pembo and the Pembo alone. In the subsequent therapy, we have the nivolumab. But here is some general guidelines for the use of a checkpoint inhibitor in our situation. Checkpoint inhibitors are recommended for any patient with classical Hodgkin lymphoma that has relapsed or progressed after autologous transplant plus or minus brentuximab vedotin. Also, it is an option for patients with relapsed refractory Hodgkin lymphoma who are transplant ineligible based on comorbidity or failure of the second-line chemotherapy. Also, post-allogenic transplant, the checkpoint inhibitor can be used in this situation. However, there is limited data regarding its use. Also, the ESMO guidelines is recommending the anti-PD-1, but after the autologous transplant and the PV. This is my final conclusion. Immunotherapy recently yielded a high response rate in heavily pretreated patients with classical Hodgkin lymphoma. It was well tolerated with a good toxicity profile in heavily pretreated patients. The new challenges with immunotherapy is how to convert PR in such patient into a CR. Understanding the mechanism of resistance will be decisive to design further treatment combination. Ongoing trials are evaluating them earlier in the course of the disease as a pre-transplant salvage regimen or as a part of the initial induction therapy. More clinical trials, of course, are needed. Finally, I thank you.
Thank you very much for this very detailed presentation. I have one question about the study of continuing anti-PD-1 post-progression. Do you recall this study if they have done also biopsy to confirm it's true progression and it's not just pseudo-progression?
I'm not sure of this point, of course.
It's very, very difficult to tell the patient you will continue even if you are in progression.
But of course, you know, we may be in a very difficult situation. A heavily pre-treated patient, while more chemotherapy is very toxic for him, and sometimes you find it's doing well for our patient. We have a mild progression, and the patient is doing well, so we may continue. I think it will be case by case.
Yeah, I understand your point. So if the patient is doing well, asymptomatic, and it's just
there is no options, no other options.
Okay, thank you very much.
Thanks, Professor.
So our last speaker is Dr. Hussam El-Zawawi, who will present to us immunotherapy in multiple myeloma.
Thank you very much. First, I would like to thank the organizing committee and the chairpersons, of course, Dr. Samir, Dr. Safa, and Dr. Elizabeth, and of course the audience who are still surviving up till now. I'll try to be very concise, and I'll try to, I know we are all exhausted by the end of the day.
We have accommodated everyone, we should do this the same for you. So
yes.
Take your time.
Thank you. My talk is about immunotherapy in multiple myeloma. I am Hussam Zawam, lecturer of clinical oncology in Cairo University. I am taking this talk on behalf of my colleague who had a last-minute excuse, Dr. Ahmad Magdi. First of all, myeloma at a glance, we have seen that multiple myeloma is 1.8% of all cancers in the US, and the survival rate is rapidly increasing due to development of newer drugs along the period from the 1970s up till now. Myeloma is a B-cell malignancy and characterized by proliferation of plasma cells, and it has a distinct presentation or distinct characteristic of development of subclones. And even if we do a whole genome sequencing for a patient at diagnosis, we will see about 5,000 mutations. And if we take this same patient at relapse, we will see about 12,000 mutations, so it presents a great challenge during treatment. The microenvironment of myeloma plays a great role in development of immunotherapy. We have the immunosuppressor cells, the T regulatory cells, and the myeloid-derived suppressor cells. And patients with overexpressing with Tregs over expression are lower survival, but patients with lower Tregs have higher survival in multiple myeloma. Other factors play important role in the microenvironment is the presence of a growth factor and cytokines, which have a bit of crosstalk between the myeloma cells and the bone marrow cells. For example, the April ligand binds to the BCMA antibody and leads to development and progression of plasma cells. Other co-inhibitory signals which are present, like the CTLA4 and the PD-L1, they play also an important role in the myeloma microenvironment, where the T cells and the antibody-presenting cells interact through the T cell receptors with the major histocompatibility complex, which initiates the immune response. And this immune response is negatively regulated by the PD-L1 and PD-1 combination. Also, it is negatively regulated by the B7 and CTLA4 combination. What about the drugs in development of multiple myeloma? We have the immunomodulatory drugs like the thalidomide, lenalidomide, and immunomide, which just tackle the myeloma microenvironment, and their mechanism of action depends mainly on inhibiting the interaction between myeloma cells and bone marrow cells through different mechanisms, which are related here in this cartoon. This is the first class of immunotherapy, and we all know, we are all familiar with this class of immunomodulatory drugs. They cause venous thromboembolism as a class effect, and we should give prophylactic measures for the thromboembolism. The other class is the monoclonal antibodies. Like the monoclonal antibodies act through different mechanisms. They either act through antibody-dependent cellular cytotoxicity, or complement development activation, or directly induce apoptosis. And we will start by the anti-CD30 monoclonal antibodies. The anti-CD38 is expressed highly expressed on plasma cells, followed by other immune cells. And CD38 especially is a good target for myeloma because it is almost expressed in all the malignant myeloma cells. Daratumumab is a monoclonal antibody against CD38. It's well established, and we have seen some trials by Dr. Gamal Fathi, like the Pollux and the Castor trial in the second line, and it's also like the Alcyone and the Cassiopeia trial in first line. The other monoclonal antibody against CD38 is the isatuximab. Isatuximab has been studied in relapsed refractory myeloma in combination with pomalidomide and dexa with also good results. This is the ICARIA study of isatuximab in relapsed and refractory multiple myeloma, showing good response rate and good survival results. The other monoclonal antibody is the elotuzumab. It is an anti-SLAMF antibody. SLAMF is a protein expressed also on plasma cells and natural killer cells, and to a lesser extent on other activated T cells. Elotuzumab is an antibody against this SLAMF. It acts mainly through antibody-dependent cytotoxicity and not through other mechanisms. The ELEQUENT trial, ELEQUENT 2, studied elotuzumab in the relapsed refractory setting with good results also, and the ELEQUENT 3 studied elotuzumab in combination with pomalidomide and dexa in the relapsed refractory results also with good results. The DARA and the elotuzumab, all these antibodies have infusion reactions, so take care during giving these drugs. The other target, or the other, not just antibody, the other target is the BCMA, the B-cell brain antigen. The BCMA, we have many targets for the BCMA. For example, the antibody drug conjugates, the CAR T cells, and the bispecific antibodies or the bispecific T cell engagers. First, the antibody drug conjugates is the belantamab mafodotin. Shortly, we will call it the belamaf. The belamaf is a monoclonal, is an antibody drug conjugate composed of a monoclonal antibody against the BCMA, combined with a protease-resistant linker. And then it has a target of monomethyl auristatin, which is the cytotoxic drug. When this monoclonal antibody binds to the cell, it's internalized, and then the lysosome destroys the linker, releasing the monomethyl auristatin, and which causes destruction of the cell. The belamaf has been tested in the relapsed refractory myeloma as a single agent in the DREAM2 study with a response rate of about 30%, and then it's tested in different combinations in the DREAM5 study. It had been tested in different combinations with different drugs, and it also has been tested in the first-line setting of multiple myeloma in the DREAM line in combination with the best induction. We have VRD. So with response rate, as we see, response rate almost about 100% in different dose categories. So this is the belamaf antibody. The main side effect of belamaf is keratopathy. About 70% of patients develop corneal toxicity, and some cases also develop corneal ulcer. So you have to, if you have this drug, you have to have an ophthalmologist with you to manage the keratopathy. The second target is the CAR T cells. The CAR T cells, we have two approved CAR T cells, the idecaptagene, Veselucel, and the ciltacabtagene. They are both approved in multiple myeloma. The ID cell has been approved through the phase 2 KARMA study. The phase 2 KARMA study included patients with relapsed refractory myeloma, and most of the cases have very high risk cytogenetics. Very high risk or very high tumor burden, and they received the CAR T cell after 3 or further lines of chemotherapy, and the results are, we can see the dose of 450 milligram. The response rate is about 82%. It's a good response rate in this high risk and highly pretreated patients. The other T cell is a bit furthermore impressive, the CILTA cell. The CILTA cell has been approved through the CARTITUDE study. The CARTITUDE study included also almost the same category of patients heavily pretreated, and we can see that the patients with triple refractory and penta-refractory are very high in this study. Also, patients received 4 or more lines, and even 64% of patients received 5 prior lines of chemotherapy. And even by this, the response rate is 97%, or approaching 98% in this category of patients with a stringent CR rate of 82%, which is unprecedented results. And this is the survival, the PFS, and the OS. There are other CAR T cells ongoing, and the response rate is ranging from 90-something% on all these CAR T cells. We also know the toxicity of CAR T cells like the CRS and the ICANS syndrome, and it has to be managed if you give these CAR T cells. The last thing is the anti-BCMA bispecific antibodies. The bispecific antibodies are antibody which contains two antigen recognition domains. The first domain binds to the CD3 on the surface of the T cells, and the other domain binds to the other target like the BCMA in this situation, the BCMA on the myeloma cell, so approaches the immune cells to the myeloma cells and causes this destruction. The bispecific T engagers are only a type of monoclonal of bispecific antibodies which has two single chain variable fragments only, not the whole antibody. It has only two single chain variable fragments. And this BiTE or bispecific T cell engager has been developed in myeloma cells under many categories like the teclistamab and the erlantamab, and the results of the primary results of these studies, like the majestic study in the teclistamab and the with the response rate of about 62%, and also the magnetism study of erlantamab showed good results. These are the ongoing phase 3 studies of anti-BCMA targets. We have seen many of these targets in development. There is a bit difference between the antibody-drug conjugates and the CAR T cells and bispecific antibodies, which is listed here in this table. So my conclusions is that immunotherapy for multiple myeloma is an effective treatment, and the CAR T cells, as we have seen, showed unprecedented data in the phase 1 and phase 2 study, up to 98% response rate, as we have seen in the CARTITUDE. The duration of response is still yet unclear. We have to wait longer time from the CAR T cell studies, and other next steps with combination of these antibodies with other drugs may show better results. And by this, I end my presentation, and thank you so much.
Thank you very much.
ليه عندكم 20 ثانية يا دكتور؟
You can make the question. What do you think about it? You can ask yourself the question. You wait.
حاجات مش عندنا.
She has a question.
دكتور
Thank you very much for the very complete presentation. I want to ask a very simple question in reality. What we noticed in our center or in our network area, and there are already data regarding that, is that with daratumumab first line, I don't know, you can use here in Egypt, yeah.
We can use it, but not in first line. We have used it, but not in first line. Yes.
Okay, resistant cases. So I don't know if you can answer if you have experience. But we noticed that there is a highest incidence of poor mobilizer.
Of course, I cannot comment on that because I have no experience on DARA first line, but all the DARA studies are add-on therapies. Something plus DARA, you can give lenalidomide dexa plus DARA, or Velcade dexa plus DARA, and other studies like the Alcyone and the Cassiopeia. DARA is an add-on drug, and even with the addition of more drugs, you can see more toxicity, of course, regarding, as you have said that regarding the stem cells, they're a bit a problem in the stem cell collection. But adding on more drugs, I think, will result in more toxicity.
No, because this is true, of course, more drugs, more toxicity. But the question was specifically to daratumumab, because daratumumab is an anti-CD38. An anti-CD38, it is expressed on CD34 progenitors. So if you give it in young people where we are either you do Dara-VTD and then you do endoxan as mobilizer of a stem cell, you see that there is an increased incidence of poor mobilizer. So actually my question was if the solution to that, in your opinion, was to delay the mobilization, maybe recovering this subset of CD34, CD38 positive stem cell.
In this situation, you are the expert. I don't know because we don't use DARA that much. But you can raise the question and you can raise the answer, of course.
Yeah, it's a very good question. So I think it's important.
Do you have comment on this question?
It's understandable. You don't have an answer. We don't have an answer. So we need to see in the future what's happening. Also because maybe delaying more, you have risk for relapses. So it's very tricky. Thank you very much.
Thank you.
And thank
so
you
much.
all. And it was really great being with you today. We enjoyed being here. And thank you, Dr. Reem. You did a great job. You're such a wonderful person. You've been, we saw you today going everywhere, every hole, trying to, really, I'm quite impressed. I'm always proud, but today I'm much more proud than before. Thank you. Excellent arrangement.
Thank you very much.
Excellent arrangement. Really. You've been standing exactly like a military in the
Yeah, I've been running around
battlefield
for the past
so really, we need an applause for her. An applause from everybody to her, really.
Thank you very much, and we will conclude this conference, not only this session, with, I think this is the best conclusion. I know that we are online. A lot of people are watching online. I know that, there's...
That's interesting.
Thank you very much.
You
See you next
really
year.
deserve an applause from everybody. And we have seen today, it's the last day, but you've been standing on your foot, going everywhere, checking on everything, making sure that everything is going great, and you did great, and we enjoyed every minute. Thank you very much.